Very much, sir, for giving me this opportunity to present this short case here. I'm the organizers. So we'll go over the cases very quickly. So the topic is looks can be deceptive. Are they? This is a 65 years old male presenting with generalized weakness and abdominal distension for 6 months. Epistaxis, loss of appetite. There was massive splenomegaly. CT scan revealed splenomegaly, and this patient also had a hanging thrombus in the aorta. LFT and renal function tests were normal. So the LFT and KFT were normal. CBC revealed a high TLC and a high platelet count of 8,10,000. There was no history of blood transfusion, no history of treatment. The patient was referred for bone marrow examination. As you can see, hemoglobin was 11.5, RBC was normal, WBC count was elevated to 20,000, and there were mainly neutrophils and band pumps, 85%, with 3% myelocytes. There was thrombocytosis. Then there was on GBP, there was anisopoikilocytosis along with presence of teardrop cells and nucleated RBCs. There was left shift, neutrophilia with left shift, and thrombocytosis with platelet anisocytosis with presence of giant platelets. So basically, there was a leukoerythroblastic blood picture. As you can see here, I've already labeled it. So there were myelocytes, nucleated RBCs, along with microcytic hypochromic cells, teardrop cells, and giant platelets. Bone marrow aspirate was hemodiluted, no fragments were seen, and there were only large platelet clumps. A biopsy was done, which revealed a hypercellular marrow, which was fibrocellular. There was streaming of cells and megakaryocytic clusters. High power view, again showing dense and large clusters of megakaryocytes. There were variably sized megakaryocytes, which were present in large as well as small clusters. We can see that some were hyperlobulated, some were hyperlobated, with hypochromatic and bulbous nuclei also seen, some small megakaryocytes. There was granulocytic hyperplasia, dilated sinuses, along with intra-sinusoidal hematopoiesis. Reticulin was definitely increased with an MF2 on a scale of 3. MT stain revealed collagen fibrosis of grade 2. IHC was done just for an academic interest actually. So CD61 highlights a lot of megakaryocytes. You can see variably sized megakaryocytes. CD34 was within normal limits. MPO was highlighting all the granulocytic hyperplasia. So a very simple diagnosis of primary myelofibrosis was suggested, and molecular testing for JAK2, CALR, and MPL was advised for confirmation. So then this patient decided to go to AIIMS New Delhi, and there the molecular testing was done. JAK2 V617F mutation was detected, and BCR-ABL was negative. So final diagnosis, straightforward primary myelofibrosis based on the classical morphology and the mutation present. So we were very lucky here, no problem, but this might not be the case every time because neither the morphology nor the molecular testing here is confirmatory in MPNs. So we all know that these kind of molecular markers like JAK2 can be seen in all three BCR-ABL negative MPNs. Similarly, CALR, MPL, and triple negatives are also very frequent in PMF and ET. So although the molecular markers will help in differentiating and telling that there is a clonal or a reactive cause behind the myelofibrosis, but these are not specific. So there are challenges in differentiating polycythemia vera, primary myelofibrosis, and essential thrombocythemia, as all three may have overlapping clinical features, laboratory features, and overlapping molecular markers. A sustained thrombocytosis and mutation status cannot discriminate between pre-fibrotic myelofibrosis and essential thrombocythemia. Therefore, a careful analysis of morphology is essential. Also, in post-PV myelofibrosis versus overt primary myelofibrosis with JAK2 mutation may be challenging to discriminate. These are the morphological features we all know as morphologists. We know that these help us in discriminating these all these various entities. So to summarize, looks are not deceptive usually. Awareness of the limitations of both morphology and molecular testing are vital, and knowledge of the clinical presentation, laboratory features, morphological features, and the molecular profile are essential for diagnosis, prognostication, and therapeutic intervention in the current era. That's it.